afternoon, and welcome to today's All Tribes Call, sponsored by Tribal Affairs Division at the Center for Medicaid and CHIP Services. I'm Kitty Marks, Director of the Division of Tribal Affairs, and joining me on today's call are my colleagues Lane Terwilliger and Cindy Gillespie. As Andrea has indicated, the topic of today's call is the Medicaid Managed Care Indian provision. And as many of you know, on April 25th, CMS issued a final rule on Medicaid managed care rules in Medicaid and the Children's Health Insurance Program. And these Medicaid managed care rules incorporated many of the provisions in Section 5006 of the American Recovery and Reinvestment Act, otherwise known as ARRA, that became effective July 1st, 2009. And CMS engaged with tribes throughout the rulemaking process to ensure that the final rule was consistent with the ARRA protections and to address any other issues and concerns that were raised through the rulemaking process and through tribal consultation. We did receive several comments from tribes, tribal organizations, including the CMS Tribal Technical Advisory Group. In light of the significant comments received on the differences across managed care authorities and the parameters for mandatory enrollment of Indians under various authorities of the Social Security Act, we committed in the final rule to develop sub-regulatory guidance that we would develop through tribal consultation to address the managed care authorities and explain those, and also to obtain any other additional comments or issues regarding provisions in the Medicaid managed care that has tribal implications. So we want to provide enough time for any questions and issues. So at this time, I'm going to turn it over to Lane to provide a general overview of the managed care rules, and then we're going to focus on the mandatory enrollment authority. Lane?
Thank you, Katie. Good afternoon, everyone. Thanks for joining this call. Just to provide a little bit of background, the final rule was the first update to Medicaid and CHIP managed care regulations in over a decade. And the healthcare delivery landscape has changed substantially since that time, so we're very pleased that we are able to incorporate several provisions pursuant to a lot of the comments that we received from you all. So we published this rule in final form in May earlier this year. The effective date was July 25th, 2016, with a phased-in implementation of new provisions over a 3-year period, beginning with contracts on or after July 1, 2017, and these would include the Indian-specific provisions. So with respect to the ARRA provisions, they came into effect in July 2009. With respect to the Indian-specific provisions, they'll come into effect in July 2017. And then with respect to the CHIP provisions, they'll come into effect July 2018. And so the reason we did this is we needed to coincide the effective dates with the dates of contracts. And now I'm going to provide a brief overview of the Indian provisions. The final rule codifies a range of Indian managed care protections for the treatment of Indians, Indian health care providers, and Indian managed care programs, including those in Section 1932 of the Social Security Act, as added by 5006 of the American Reinvestment Recovery Act. I'll probably refer to that as ARRA 5006. These provisions, again, were effective July 1st, 2009. The final rule applies the Indian protections to all types of managed care programs, including managed care organizations, prepaid inpatient health plans, prepaid ambulatory health plans, and primary care case management entities. The Indian-specific provisions, which are titled Standards for Contracts Involving Indians, Indian Healthcare Providers, and Indian Managed Care Entities, are located in the Medicaid rules at Section 438.14, and also, as I said before, made applicable to CHIP. These provisions allow Indians enrolled in Medicaid and CHIP managed care plans to continue to receive services from an Indian healthcare provider and ensures that Indian healthcare providers are reimbursed appropriately for services provided. The final rule also addresses other tribal issues, such as sufficient network and payment requirements for managed care plans that serve Indians, network provider agreements with Indian healthcare providers, state tribal consultation requirements, and referrals and prior authorization requirements. The next couple of slides go over the definitions. I'm not going to go over them, read them off to you. They're consistent with our other definitions that we had in Medicaid, but I just wanted to call them out. We've codified them in the rules, so they're all in one place. Now, next I'm going to talk a little bit about network sufficiency standards and provider choice. So first of all, the rules codified the Indian's right to use the Indian healthcare provider of their choice. So any Indian who's enrolled in a non-Indian managed care plan and eligible to receive services from a network Indian healthcare provider to choose that Indian healthcare provider as his or her primary care provider. Also, every managed care organization, we call them PIPs, PAPs, or PCCM entities, those are the different managed care types, must demonstrate that there are sufficient Indian healthcare providers participating in the network to ensure timely access to services available under the contract from Indian healthcare providers for Indian enrollees who are eligible to receive these services. In the event that timely access to Indian healthcare providers in a network cannot be guaranteed due to few or no network participating Indian healthcare providers, Indian enrollees can be permitted to access out-of-state Indian healthcare providers, and it's also deemed good cause for an Indian to disenroll from a managed care entity. I have a couple slides about enrollment in an FQHC, or when you're not at an FQHC. We'll go past those. They're pretty technical in detail, but the slides are there for you to see, and there's provisions are in the rule. In the final rule, what's new is that we actually called out the Indian healthcare provider's right to receive payment. And what we included in the rule, because we've had a lot of tribal comments about problems receiving payments and the wraparound payment, we called out in the final rule the Indian healthcare providers, whether they're in-network or not, must be paid the applicable encounter rate or fees for a service rate. The other thing that we called out in this final rule is that states may allow a managed care entity to directly pay an Indian healthcare provider the encounter rate, and then the state can settle up with that managed care entity on the back end. So that is a new provision, and it addresses several issues we've been hearing in Indian country concerning payment and delays in payment. What we also did, a new provision, is we talked about avoiding duplicative visits for referrals. So under the new rules, an Indian healthcare provider may directly refer to a network provider and avoid the duplicative visits that required an in-network referral. So your Indian beneficiary, in order to receive that referral, can get it directly from the Indian healthcare provider and does not have to go to the managed care entity, receive a referral, and then get their services. So we thought this was important to avoid duplicative visits for referrals, and it addresses those issues. The next slide we have concerns auto assignment. And while we didn't have a specific provision in the rules, we talked about it in our preamble. And what we've been hearing out in Indian country is that there are many different ways to address this issue. And so, and also auto assignment works very differently among different MCO plans and works differently among states. So we at CMS strongly encourage you to work with your state on coming up with an assignment methodology that fits the tribal provider network in your state. Now we're going to talk about mandatory enrollment into Medicaid managed care and preface it on strongly encourage, not only states, but you all to talk about these kind of mandatory enrollment arrangements. So to require Medicaid or CHIP beneficiaries to enroll in managed care to receive coverage, a state must obtain approval from CMS either through a Medicaid state plan amendment, a 1915 D waiver, that's known as a managed care waiver, or through the Section 1115 Medicaid Demonstration Authority. Consistent with CMS tribal consultation policy and the requirements of ARA Section 5006, states are required to engage in meaningful consultation process with federally recognized tribes and or Indian healthcare providers located in their state prior to the submission of a SPA, a state plan amendment, a waiver, or a demonstration having tribal implications. And states also must consult with tribes in accordance with their ARA consultation policy. States do have the authority to exclude Indians from mandatory enrollment in managed care, and I will get into the details of that in my next slide. But CMS it strongly encourages states to engage in meaningful consultation with tribes and tribal health programs before mandatorily enrolling them Indian beneficiaries into managed care. And now I'm going to talk about the three separate authorities, and then we're going to turn it over for some questions. The Medicaid State Plan Authority is the first authority we'll talk about. States can implement a mandatory managed care delivery system for certain populations through a Medicaid State Plan amendment that meets the standards set forth in Section 1932 of the Act. However, under Section 1932, the Act prohibits states from mandatory enrollment of an individual who is an Indian into managed care unless the managed care entity is contracted with the state as an Indian managed care entity. So as the status of that right now, we don't have any Indian managed care entities so far, so that right now we have no mandatory enrollment. Next, we're going to talk about the 1915 D waiver. This is known as a managed care waiver. CMS may grant a waiver under Section 1915B of the Act that permits states to require all Medicaid beneficiaries to enroll in managed care delivery systems, including Indians. In reviewing such requests, CMS will consider any input the state received in the tribal consultation process. A state and its tribes could reach mutual consensus to exempt Indian from the 1915B managed care waivers for reasons such as network sufficiency, contracting and payment difficulties, I would say maybe historical contracting and payment difficulties, and access to culturally appropriate providers. So to kind of sum that up, a state can specifically exclude Indians from mandatory enrollment in managed care under the 1915B authority. Next, I want to talk about Section 1115 Medicaid demonstrations. States have the option to exempt Indian populations from mandatory enrollment in managed care delivery system, permitting Indian populations to obtain access to health care through a fee-for-service delivery system. Historically, CMS has not approved Section 1115 demonstrations that have mandated Indians into managed care. Those approvals were the result of state tribal consultation with CMS and CMS tribal consultation with participation from the state. We strongly encourage states and tribes to engage in meaningful consultation when considering mandating Indians into managed care. States are required to consult consistent with the process outlined in its approved ARA Tribal Consultation Plan State Plan Amendment. The last managed care entity I'm going to talk about First, I'll cover the Indian Managed Care Addendum. We received several comments concerning the Indian Managed Care Addendum that we have as a voluntary basis for the marketplace. This addendum is still under review and making its way through CMS clearance. CMS will hold a consultation through an all tribes call before releasing this addendum. So what the ITU addendum does is it outlines all the federal laws, regulations, and protections that are binding on managed care entities, including MCOs, PIPs, PAPs, and PCCM entities. These are just all the different types of managed care authorities. And identifies several specific provisions that have been established in federal law that apply when contracting with an Indian healthcare provider. The use of this ITU addendum benefits both managed care entities and Indian healthcare providers by lowering the perceived barriers to contracting with Indian healthcare providers and minimizing potential disputes. The ITU addendum also helps to integrate Indian healthcare providers into managed care networks and ensures that Indian beneficiaries have access to a comprehensive and integrated benefits package, and to ensure that the Indian can continue to be served by the Indian healthcare provider of their choice. This final rule also codified the Indian Managed Care Entity, which was established under R 5006. And so they codifies the Section 1932 of the Act that define Indian Managed Care Entity and sets out the special rule for enrollment in an Indian Managed Care Entity. The special enrollment rule permits an Indian Managed Care Entity to restrict its enrollment to Indians in the same manner as Indian healthcare programs can restrict the delivery of services to Indians. So far, we have not tested this particular provision of ARA. We had discussions with different tribes and different states about this entity, but we still have not tested it. So we're looking forward to working with you all when that comes up. And now I think we're going to turn it over for questions and comments. Kitty?
Okay, thank you, Lane. And we appreciate any comments, questions you might have. I know that this is a lot of information, but what we're trying to do through these slides and through our sub-regulatory guidance is to take all the various Indian provisions that are in the Medicaid Managed Care Rule, and that Medicaid Managed Care Rule ended up being 1,400 pages long. So what we're doing through the sub-regulatory guidance is pulling all of the Indian provisions into one document, which we call an informational bulletin, and much of the information that is contained in the slides is what you'll see in the informational bulletin. But as we indicated at the beginning of the call, we want to get your feedback if you have any questions or issues regarding our explanation of the mandatory enrollment rules. I hope we made it clear that we believe that there's flexibility, states have flexibility, and we encourage tribal consultation. And then, of course, we can answer any other questions that you might have regarding the Medicaid Managed Care rules or problems that you're having. So, Andreas, I think at this point we'll go ahead and open it up for any questions or comments.
At this time, if you have a question or comment, please press star 1 on your telephone keypad. Again, that is star 1 for any questions or comments. And again, for any questions or comments, please press star 1 now. And we do have a few in queue now. Your first is from Marin McCabe from Urban Program.
Hello, thank you for the presentation today. I had a quick question just for clarity on the FQHC program. Am I correct in understanding that an urban Indian health program contracted with the state as an FQHC is permitted to refer into a network which they are not participating in and should receive at least some portion of the payment from the managed care entity and the balance from the state, or if the state assigns the responsibility, then full payment from the entity?
This is Cindy Gillespie, and it does protect urban Indian organizations who are enrolled as FQHCs in the same manner as other Indian managed care, Indian health providers. The payment could be made in part or in full by the managed care, and then supplemented by the state if necessary to get to your regular encounter rate. Or the state could carve out the payment. A couple of states have done that and adjusted the managed care rates with the managed care entities accordingly. So as far as how you get the payment, it could vary state by state, but you are guaranteed your full FQHC encounter.
Thank you. And that's effective July 17th?
Yeah, that's effective with the new contract July 1st, 2017. But we know that a lot of arrangements are still in existence, so that does not prohibit the state, from paying these rates now. And I pulled up the slide that explains that when an Indian healthcare provider, including the urban program, is an FQHC, that they can be paid, or they must be paid, the FQHC payment rate, and then plus the supplemental. So,
thank you very much.
Okay. Thank you, Mark.
And again, if you'd like to ask an audio question, please press star 1 at this time. Questions or comments, star 1. Your next question or comment is from Thelma Shindu from Jimenez Health Center.
Hi, this is Carol Lucero with the PRC department here at Jemez. And I just wanted to ask you to go over, because I barely kind of caught the information when you were saying that when a referral is established or is made from an IHS facility, and just want to verify the rest of the information, because you were saying, I think, that it does not need to go to the managed care provider and that it can go straight to the providers wherever we're referring them. Is that correct?
Yes, that is correct. An Indian healthcare provider can, when they're referring one of your beneficiaries out, you don't have to refer them to a primary care provider within the network first. So under these new rules, you can directly refer them to the specialty care, or what you're referring them to directly, without going through that duplicative process. Does that make sense?
Yes. Thank you.
Thank you. And that provision in the managed care rule was something that we were able to address based on the many, many comments that we received on the issue of individuals enrolled in managed care and having to receive duplicative visits. So that's a good provision there.
And again, if you'd like to ask a question or make a comment, please press star 1 now. Next question is from Karen Kennedy from Muckleshoot.
Go ahead, Karen.
Karen Kennedy, if your line is unmuted, please unmute it.
In regard to the encounter rate, we were just informed of all of it. We recently became aware of the situation that was going on. And we had a question regarding Medicare and Medicaid billing. Is it correct that if we're billing Medicare and Medicaid, the way it stands right now, we're allowed up to 4 encounters per day? Under this new ruling, are we going to be reduced to 1 encounter billing, which would result in a loss of a huge amount of dollars for the tribal entities?
This is Cindy Gillespie again. The managed care regulation does nothing to change your state plan ability to bill however many times are allowed in your state.
Okay, and so we're required to do all of this. This has already been implemented, and this is something that this is already active and in place and implemented. So the tribes wouldn't have a right to not engage in this managed care. It's an absolute requirement.
No, you have the choice whether to enroll with the managed care network or not, as a facility. whether or not you do, your normal payment for the services you render is guaranteed, through the managed care entity and or the state.
Okay. Thank you.
Sure.
Again, for any questions or comments, please press star 1 now. Your next question is from Travis Starper, Navajo. Travis, if your line is on mute, please unmute it.
Hello, good afternoon. My name is Travis. I'm calling from Flagstaff, Naco Family Health Center. We are in an FQHC facility. Question I have is in regards to the contracts. Are we looking at to draft up contracts with the state in regards to this new change? And also, I wanted to state about the question that was asked before about the facility opting in or participating. I think that was clarified. That facility will have the final say in participating in this new directive. Thank you.
Well, Travis,
I was just going to say that it is the facility's option to participate or not with the managed care plan. And then, Kitty, I'll let you go with the...
Yeah, I'm sorry. I pulled up that slide because this is a really important provision that was in 5006. It's been in 5006 since 2009. But whether the Indian healthcare provider is an FQHC or an IHS tribal provider, and whether or not they're enrolled as a network provider in the managed care plan, they must be paid by the managed care plan, and then the state has to pay a supplemental up to either the FQHC payment rate if you're an FQHC or the encounter rate. So that was an important provision contained in 5006 to protect Indian healthcare providers when they would provide services to individuals enrolled in managed care to ensure that they get adequate reimbursement, whether they are a part of the managed care entity or not. You do not have to be a network provider in order to receive either the full FQHC rate or the full encounter rate. And what the managed care rule does is clarifies that states have the option to make arrangements with the managed care entity for the managed care entity to pay the full encounter rate up front to the Indian healthcare provider and settle up with the managed care plan later. So this arrangement lessens the billing by the Indian healthcare provider because they only have to bill once to the managed care plan. They don't have to bill to the managed care plan for the managed care rate and then to the state for the supplemental. Is that clear, Travis?
Yes, it is. Thank you.
Okay, thank you.
And our next question is from Lisa Naves with Pueblo of Jimenez.
Hi. Now I have two questions, actually. I wanted to piggyback on Carol Lucero's question initially. I thought I heard you say when IHS providers, as primary care providers, refer out to specialists, they're allowed to refer out to network providers. Did I hear that right?
Yes.
So the specialists need to be within the MCO network.
Yes, if the patient is enrolled in an MCO, the Indian health provider will need to make referrals to specialists within the network.
Okay.
But they don't have to go back to some other primary care provider. They may have been randomly assigned to get that referral.
Sure. So, and my second question then is, we have a few of the MCOs here in the state of New Mexico that subcontract out some of the services that are available to Medicaid enrollees. While we haven't had issues with getting paid. I shouldn't say haven't had, but what we're finding is that some of those subcontractors do not acknowledge us, or acknowledge ITUs, I should say, as providers the same way that the umbrella MCO does. And so some of the services end up having to go out because it's not the primary MCO as the payer, I guess. I don't know how that works, but I know we've run into it a couple of different times where we'll have to send people elsewhere for services that are available here because the MCO's subcontracted provider doesn't know what an ITU is.
Okay, so the regulation is the first time we've really addressed in writing the ability of the Indian health providers to make the referrals without going back through a primary care provider in the network. So it's a new thing. I think maybe we should take your specific situation offline. Maybe you can email Kitty or myself, and we can research what's going on.
Okay, thank you. Thank you, Lisa.
Our next question is from Kirsten Powell with the tribe of Port Gamble, Staya.
Hello, can you hear me?
Yes, please go ahead.
Yes, thank you for the webinar. And I am wondering if a tribal program has a problem with an MCO, how will any grievances or be handled? Would CMS be involved in that at all, or is that between tribes and state and the insurance commissioner? I don't know if CMS would be involved in any situations like that where this is not working for a tribe.
I think it would depend on the situation. I mean, there are some things that the state insurance department has jurisdiction over with insurers. I think it would depend on whether it's a claim issue or what exactly the issue is. But you can, if you can't get satisfaction through the managed care network or the state at any time, you can always contact Tribal Affairs, right, Kitty?
Right, and you can always send a question through our email. It's tribalaffairs, all one word, at cms.hhs.gov.
And I think I'd like to add something to that. I think we could have probably opened with it. One of these things that these rules do is kind of dismantle the traditional managed care arrangements that go on in the States, where you have the managed care entity in the middle between the beneficiary and the provider, and the state on the other side, and where they're not managing the managed care entity. So a lot of these provisions that go into effect, not just the Indian provisions, but the managed care rule, helps to make the managed care experience for the beneficiary and the participating providers a lot more responsive and holds the state responsible. So I think that's one of the good things about these rules, not just the Indian-specific provisions, but the rule in general.
Andres, are there other questions?
Yes. And we have Al Santana with Tribe Crib.
Yes, thank you. Thank you for the call. So my question is twofold. Is there a date certain or goal for when the information bulletin will come out? And secondly, I imagine that the Indian addendum now will have to be, reworked to reflect the changes. Would it be possible to rely on that Indian addendum before the bulletin is out and released?
But just to go back, this is Kitty Marks to answer your question. We hope to have the informational bulletin released very, very soon. We do we have received, as part of the comments that we received from the tribes and tribal organizations, an ITU addendum. And as we indicate in the final rule, the use of the ITU addendum is not going to be mandatory on the managed care entities, but we will work with the states and the managed care entities to encourage the use of the ITU addendum. In reviewing the ITU addendum, for us to issue it as part of our informational bulletin to be used as a template, it has to go through clearance, and that's where it is right now. But if you have an ITU addendum and you're able and you want to enter into contracts with managed care entities now, you could use the ITU addendum that was submitted as part of the comments. I think it was the Tribal Technical Advisory Group and the National Indian Health Board that developed the template. That template was developed based on a similar addendum that was issued as part of the Medicare Part D program and the marketplace. And it really is a tool to help alleviate and negotiate certain terms in the managed care contract. So I don't see any obstacle if tribal organizations want to use their own ITU addendum at this point, but we will be issuing one as part of our informational bulletin and sub-regulatory guidance.
Thank you very much. That answers my question.
Good, thank you.
And our next question is from James Roberts with Tribe Inc.
Yeah, good afternoon, Kitty. It's Jim with ANTHC. So I have a couple of questions, and I don't know if this might be able to get addressed, recognizing that the sub-regulatory guidance has already gone through some internal deliberations with CMS. But it gets back to Kirsten's comment about network adequacy and offer of a contract. And then the second thing I wanted to talk about was the documentation requirements for prior authorization. So, I appreciate the rule, and I think you guys did a great job to address those two issues in the regulation. But one of the concerns that we might have, and I can see evolving, is that the managed care plans or some of their subcontractors would make the documentation requirements for medical necessity so rigorous that they would kind of create an additional barrier around this prior authorization requirement. So I'm wondering if the sub-regulation or the sub-regulatory guidance is going to talk a little bit about the minimum standards for to document medical necessity when making a referral when a tribal health program is not part of either have a contract or a network provider in a managed care plan. And then secondly, our experience with at least the offers to contract with QHPs inside the insurance exchange has been kind of lackluster in the sense that a lot of times the Office of Insurance Commissioners and the exchange, and in this case it would be the single state agency, kind of punt back and forth. We get ping-ponged around on what are some of the requirements to measure network adequacy, or what's truly an offer to make an offer to contract with the tribal program. Can you speak a little bit about whether the sub-regulatory guidance will get into that, or if there's some strategies that you all have in mind to address those issues?
Yeah, I don't think that the informational bulletin goes into detail about the network adequacy, and we did make it clear in the preamble language that, like I said, we can't make it a requirement. But I think that, working with our colleagues in the Division of Managed Care, I think that there's a strong sentiment at CMCS that we really want Medicaid managed care to work for Indian country, and I think that's why the ITU addendum is helpful, and to encourage Indian healthcare providers to either become network providers so that they, can make referrals to other specialists, as in-network providers. It's a little bit more challenging if you're an out-of-network provider at least now you can make referrals back to in-network providers, but you still need to follow the prior authorization, utilization management criteria. I don't know who's breathing, what that is, that noise in the background. But it's our understanding that a lot of that is being done now. If you have a patient that has a particular type of insurance, have contacts with that insurance office and say, hey, this patient needs to go see such and such specialist, that hopefully those working relationships are in existence. But our office and our Division of Managed Care, along with our regional offices, are available to provide technical assistance or to help, ensure that these Indian provisions are implemented correctly without too much difficulty.
Okay, thank you.
And that was the last of the questions.
Okay.
If anyone else would like to ask a question, just press star 1. And we do have another question from Angela Wilson with Tribe CA Rural Indian Hill.
Hi, Kitty. This is Angie Wilson. Great to hear you on the call, and Cindy and everyone. I just have a quick question, just listening in. And basically a question around the Prompt Payment Act within ARA as it relates to Medicaid payments back to the tribes. So I don't know if the Medicaid Managed Care regs confirm that eventually pass-through payments will be restricted in the future. We're having issues in this state in regards to how quickly or how slow we're getting reimbursed for our encounters, especially when they have to encounter the managed care organization. So if we have a tribe who is simply fee-for-service, those payments are going through no problem. They're getting a quick return on those payments as they should. But if it goes into a situation where we have a beneficiary who is enrolled in managed care, we have to do the Code 18 wrap. The problem with that is that we are more often than not getting the full return on the 18 wrap. Or usually what happens is if there are 2 encounters happening in one day, which California is allowed only 2 encounters, usually that second encounter on that same day will be automatically denied. And when that happens, it really puts the pressure on the clinics on it's very costly to the tribes on their administrative costs and their billing staff having to continually, try to get their money back through that grievance process on the denials and rebilling and all that. So what ends up happening is when we submit our payments through or our claims through, and we don't get the full remittance from the MCO, which usually happens, then that prompts the audits and investigations process. So, for instance, this year we would be working on the prior year's outstanding encounters that are owed, and that be going through that audit process. So next year we would get a 60% settlement. And then 3 years later, we would get the rest, the 40% of what we were owed on our original encounters. So there's concern, certainly, about the Prompt Payment Act for these encounters coming through, and concern that, one of the things is we also want managed care, Medicaid managed care to work for the tribes, but there has to be a pathway that gets our payments back to our tribal clinics in a timely manner. The administrative cost happening to these tribal clinics is, in some cases, the tribes give up just trying to go after the rest of what's owed because they do not have the amount of staff to keep up with the administrative work on that. So is it possible when you look at, the regs for Medicaid managed care, to look at options of either the full payment, the full encounter being paid by the MCO, or that, there's a pass-through continues to happen for the tribal health care delivery system, where if someone's in the managed care, those are passed over straight over to fee-for-service from the MCO. There just has to be a better result on that, and I'm just curious how that ties back into the Prompt Payment Act within RI.
Thank you, Angie, for your comments.
This is Lane Terwilliger. Right now, we're working directly with the state of California and our regional office, our Region 9 office, directly on that payment issue. We've heard that, and we're working directly. The state so far has committed to make a correction. We're still working on that issue, so we hope to have a resolution soon, and I'm not sure exactly how we're going to be rolling out that resolution, but we have heard of this issue, and we're trying. We're working both with our central office in Baltimore and with the regional office and with the state of California to resolve this issue. We take it pretty seriously.
And as we've talked about as well, now it's clear under the managed care regulations that the state can make arrangements with the managed care organizations to pay the encounter rate, completely, and then the state and the MCO can settle up the difference. And so that has been effective in some states, and now it's a clear option per these managed care regs. So we hope to avoid situations like tribes are experiencing now in California.
We really appreciate it. Thanks so much. It certainly has been beneficial in other states, and we get our reimbursements back so quickly. We really appreciate all the work on that, Lane, and also acknowledging that, Kitty. We certainly appreciate it because it is a significant barrier here.
Thank you.
Thank you.
And there are no more questions.
Okay, if there are no more questions in the queue, Cindy, do you have anything else to add, or Lane?
I don't. Thank you.
No, and I don't. Thank you very much.
And I put up the email box. If you have any questions, you don't have to get off the call. If you have any questions or comments, please feel free to send the email, your question through this email. We also will be posting the PowerPoint slide and the recording of this All Tribes call on our website. I think Brandon put the address up there. That's our cms.gov Outreach and Education website page, and that should be up in a couple weeks. And then in addition, please look for a Dear Tribal Leader letter that will be going out, we hope, very shortly, and we will be forwarding a copy of the ITU Addendum because we want to get input on that. And then we will be issuing a full package of the informational bulletin, taking into consideration comments that we heard on today's call and the comments we received to the ITU Addendum, and that should go out, we hope, as soon as possible as well. So, like we said, we want to make sure that Medicaid managed care works out in Indian country, and our office is here to provide technical assistance, and of course working with the regional CMS Native American contacts and our Medicaid Consortium office. We are available to answer any questions, address any issues that you might encounter. So this mailbox is the best way to get hold of us. That's monitored on a daily basis.
Hi, Kitty.
Yeah.
One question did pop up. We have a Deborah Alvarez with, with Indian Health.
Mm-hmm. Hello. Can you hear me?
Yes.
Oh, okay. I was just wondering on the where the states could waive that participants or that patients, Indian patients, would have to belong to a managed care plan. I work in an Indian health facility where we're in a very rural area, and the CCO, there's like one CCO in our area, and their offices are like 15 miles one way away. And then there's another area called the Dalles, which is even farther. And we, a lot of our patients have a hard time getting there. Well, also the state pays a per patient per month management fee to those people that are on that CCO's list. And the list is just made up, just kind of not, I don't want to say at whim, but they just take some patients become part of the CCO and some patients don't. And they don't know why, they never heard of the doctor before and all that. So it takes us a lot of time for our benefit coordinators to, of course, disenroll them so they could get into the, disenroll them so that they could, a lot of them, have our doctors as their main providers. Well, what's happened is now if we waive that and they become, or the state of Oregon agrees to waive that, can they do that for just a certain population group of Indian people? Because also there are urban Indians in the area who that works really well for them because they have a lot of different CCOs that they could choose from. And then secondly, if the state does waive us from that, does the CCOs providers, because of course that also is a small community in Central Oregon, the towns around the reservation, are they still, because of ARA, do they still have to accept our patients when we refer them?
This is Lane Twilliger. I think there's a few questions there. With respect to going back to kind of the basics, the Oregon Health Plan, as I understand that Section 1115 demonstration, allows Indians to opt into the managed care. Is that your understanding as well?
Yes, they can if they would like to. We've had a couple that have, but mostly 90% of the population, 95% does not.
This is Cindy Gillespie. Can I ask a clarifying question on the CCO? Is this for a specific type of service like mental health or something like that?
No, the tribe, actually we have a tribe, the tribe here handles mental health. Ours is for if we refer them to a specialist in the Central Oregon area, the Madras, Redmond, Bend area for oncology or any other,
Okay, and there's only one provider for those.
There's only one CCO. There's only one CCO in the area.
Coordinated care organization.
Yes, like an MCO.
So we might actually need maybe to get all those questions and dig a little deeper, I think. What do you think, Wayne?
Yes, we can do that as well, but I want to kind of preface this is that if your individual beneficiary, if you can get them to the CCO of your choice, and stay enrolled in that, they have the ability, even before these rules, to access their Indian healthcare provider of choice. So it doesn't always benefit your beneficiary to go in and out of managed care when your beneficiary already has the ability to access their Indian health provider of choice. So they don't have to enroll or disenroll in order to get access to the specialty services that you want. So I think that we can do this offline and work through it. I've been working with some individuals from your state on those questions and issues in Oregon.
That sounds great because, the waiver would be perfect, but then perhaps we couldn't get to see the specialists in the CCO. And they would want us to have, the choice. And then the other thing that, because I work in the business office at Indian Health Service, that really complicates matters for me personally is that, the CCO is paid, like I say, for case management per month. And in the state of Oregon, and they aren't really even managing that person's care. The providers at Indian Health Service and our records department, our nurses, everyone here in our Indian Health Service has been managing that patient's record. So I just don't think that's fair also because they want them on their CCO list because they receive that. They receive that payment per month.
Right, so you're stating that the CCOs are getting paid for services they're not providing to your beneficiaries at all, and that you're providing that service and you're not getting you're not?
Well, as far as case management is concerned, but in order to send one of our patients, say, to Bend, 50 miles away, send one of our patients away to Bend for an oncology appointment or a referral, then they are. Then from that point on, they are. But as far if they want to keep them on the, if they put them on the CCO on, say, October 1st last year, and they don't get referred to an oncologist because no one, they don't report any different, any difference in their health until January, that CCO is collecting all of those case management dollars per month per patient, and we're actually doing all of that work here ourselves at Indian Health Service, and they don't actually hear the patient until we refer them to the doctor, to the provider in Bend or the specialist.
So this is Cindy Gloss, why do they have to go to the CCO if they're not really, did they opt into managed care?
No, the state of Oregon, it randomly puts our people who have Medicaid on CCOs. And the only CCO we have in the Central Oregon, which is Bend, Redmond, and that, is, the main one that we use is just one organization, Pacific Source. So would the new rule that allows you to make the referrals directly take care of that problem? I would hope so. I think that's really going to make a big difference for us. But what I'm concerned about is that because it says in the new rule, it says that the state can waive Indians from having to belong to the CCO. And when they do that, or if they do that, if we ask for our patients to be waived from having to belong to a CCO, would the CCO still have to accept our referrals for specialists?
Why would your referrals go to the CCO?
Because they have all the doctors and specialists have in Oregon have them belonging to the CCO. They have to join the CCO.
Okay, so they're in like an MCO, but you should be able to make direct referrals under the new regulation when it goes into effect.
Okay.
First of all. Second, I thought it was a voluntary enrollment for Indian patients, so I don't understand why they're getting assigned.
Yeah, they just have always we've always had that problem. We've always had that problem in the state of Oregon. So they try to fix it, but they just can't get it fixed, in their system. So it comes out that some people are referred, and since we have, 2/3 of our population on Medicaid, it affects a lot of people, and it's hard to keep track of who all is on CCO this 3 months, or maybe they've fallen off a month and they get back on and they're not on the CCO. The CCO in our area.
Yeah, maybe Lane would look into that, because I'm not sure we quite understood that's how it worked.
Okay.
And Deborah, this is Kitty Marks. You work for the Indian Health Service?
Yes, I do.
Okay, then we can find you on the global, and why don't we set up a separate conference call?
Sounds great.
We're familiar with these issues, so we're hoping that these rules will alleviate some of this, but we'll set up another conference call and talk to you more about it.
Thank you, Kitty. I'm here at Warm Springs Health and Wellness Center.
Gotcha. Okay, thank you, Deborah.
All right, thanks.
And now we have, go ahead. We have one more question.
Okay, great. Thank you.
It is Gerald Folsom with Lumni.
Hello?
Yeah, Jerry, go ahead. This is Kitty Mark. How are you?
Hi, Kitty. I just wanted to say this last phone call was the most important one. You need to get that lady onto the first of the call, because that tells us exactly what's going on, is that the limited health care dollars available for Indian people are being shifted to other people without any services whatsoever. And those of us that are we're old enough to remember when Ralph Nader wasn't a presidential candidate and he started this consumerism movement. We should not be taking this. Money for nothing is a fool's game, and that's exactly what they're doing with managed care. And I think I just wanted to say also that I think your rules are a step in the right direction and refreshing. That's all. Thank you.
Okay, thank you, Jerry. Yeah. It's, well, the Medicaid managed care rules have not been updated since 2002. And, I think over 60% of the Medicaid population is enrolled in one form of managed care. That's why the overall rules are important. But I think that the Indian provisions, most of them are contained in ARA, and then based on all the tribal comments we received, I think the Indian provisions are very, very important. And so that's why I think this informational bulletin, which will take all the regulatory language, put it into a plain English, easily readable document, will be helpful. So, and then we'll straighten out some of these issues that we've been hearing. So, very good. Thank you. So, Andreas, are there any other people in the queue?
We have one that just came in. Sanxinere Banel with Pueblo and Salinan.
Hi, can you hear me?
Yes, go ahead.
Oh, hi. Hi, Lane and Kitty and Cindy and Deb. This is Sanxinere Banel from NARA Northwest. And I wanted to comment on the auto-enrollment of the CCOs that is happening in Oregon, even though it's not supposed to, but it's kind of case by case. And so, Deb, I didn't get your first name. I thought it was you, but I wasn't sure. That's why I got on. We do have a team at the Oregon Health Authority that is working specifically on these tribal issues, including tribal members being enrolled in a CCO when they didn't want to, or it could be anything, really anything having to do with Medicaid and CHIP. So we need to connect, and I'd be happy to help. So I have your contact number, Deb, and I will be getting a hold of you to chat with you more about that.
Thank you, Sanxinere. Good to hear your voice. And, as Lane indicated while we walked through the slides, I think that there is a lot more flexibility than we've been aware of before as far as auto assignment. I mean, some states do it by zip code, but if there's a way through tribal consultation as states develop these managed care plans, if Indians are going to be mandatorily enrolled in managed care, at least improve the auto assignments, to their Indian healthcare provider that they use. So,
and we've been hearing lots of different ways to do it. Like, for example, listing all the Indian healthcare providers in some kind of drop-down menu to make sure, and using the zip codes to assign individuals. While that doesn't capture everyone, it can capture a lot, and so you won't be disenrolling as many people. We've heard about that, but I think also you need to, we'll talk about this later offline, but the state needs to be able to identify who's an Indian with respect to this, so you're not having the hit and miss with some individuals being assigned to a CCO and some individuals not. That's why it's hit and miss. So I think there's a few things going on in Oregon that we can work on with you.
Okay. Okay, thank you.
Now we have Lisa Maves with Pueblo of Jimenez.
Go ahead.
Weigh in on this. Oh, I'm sorry. Hi. I was trying really hard not to weigh in on this, but I have to. We had a similar issue happen in the state of New Mexico when the new ACA rules rolled out at the beginning of 2014. A few of us spent the better part of probably 4 to 6 months trying to get some of our non-mandatory population unenrolled from being auto-enrolled in an MCO. When we actually pressed for an answer to that or why that happened, in the face of having been promised otherwise just, a couple of months before, we were given administrative simplicity as an explanation for it. It's like, well, I don't think Oregon, you're not alone. Been there, done that. That's it. That's all I wanted to say.
Okay, thank you, Lisa. Yeah, so if there's feedback on better ways to do auto assignments, I guess, like Lane said, if there's a way to identify the individual, as an IHS beneficiary, user of an Indian healthcare provider, we're welcome to that. The regulations are not specific right now, and the informational bulletin is not going to be specific either. But if people have ideas, or if we have examples, or if we think we should include examples of ways to improve this, we're welcome. We welcome those type of comments and suggestions too.
And there are no more questions.
Okay. All right. Well, we appreciate everyone's participation on today's call. We received a lot of good feedback, and we appreciate all the questions. We'll follow up with those individuals in Oregon. It sounds like some work needs to be done there. And again, if you have additional questions or comments that you'd like to submit, you can send them to our Tribal Affairs email box, tribalaffairs@cms.hhs.gov. And I want to thank my colleagues, Lane and Cindy, for joining me on today's call. Again, we appreciate the feedback, and we look forward to talking to you in the near future when we talk about the Medicaid Managed Care ITU Addendum. So thank you all, and have a good day.
Presenters, please stay on the line. And this concludes today's conference call. You may now disconnect.